the example I mentioned previously brings in a lot of changes for the role of the doctor in cancer management, because there will be an increasing anticipation that from patients and from the standard of care, the state of the art, that there will be more reactive dosing, more reactive treatment to individual patients and their responses. That brings in a lot of interest in terms of a better practice of medicine, in my view, but it also brings in challenges. So how does one actually manage that in terms of reimbursement? How does the doctor find time with the current, what we do anticipate is the next generation of companion applications that actually require doctor input? Initially, those approaches can actually bring in more stress and more work for doctors, if we're talking about doctor in the loop, but response to patient physiology. It is actually easier to have more traditional approaches to care, which are slightly fire and forget, come back and see me at a set appointment time, rather than approaches which include an aspect of home or remote monitoring. We've seen this in other fields of medicine, such as in management of heart, arrhythmia, pacemakers, internal defibrillators. Once you introduce reactive systems, there are big questions about reimbursement, about how doctors interact with those systems, what their responsibilities are, and liability in case of emergency. And that will also need to be worked through in the cancer area as we see increasing solutions which depend on doctor input. That sounds like an unsolvable problem, and I actually think it is if we don't include greater AI within solutions. And I think filtering through with closed loop, AI-based closed loop solutions on responsive dosing, adaptive dosing on the basis of side effects, on the basis of effect, for many medications, including cancer medications, actually makes sense. So you don't need to have a doctor involved in every single decision. And the careful design of such approaches where doctors are brought in where doctors are needed, and you avoid a situation of massive alarm fatigue, massive overload of doctors, the incompatibility with round-the-clock monitoring with the normal lives and shift patterns of doctors. So I think AI is part of the solution there. This is not going to be a sudden revolution from one day to the next. It requires careful design in terms of how we think about the delivery of medications to patients, and how medications are no longer going to be static things. They're going to be dynamic things. They're going to be their combinations, how we decide in terms of which medications we give, including through new forms of companion diagnostics and the ongoing use of companion diagnostics in order for monitoring therapy based upon AI-interpreted markers of disease and response to disease. This will be a part of the future of medicine, but it's a part of the future of medicine that we can't just kind of wave an AI. AI will solve all of the problems. It requires slow work through, and it requires integration with current regulatory frameworks. A major part of the paper I published was identifying a fundamental problem in this space. And the problem is that in past approaches to regulation, drugs and devices are really separate things. There was drugs regulation, and drugs are assumed to be static, to be unchanging, to be released as a chemical, approved as a chemical, which then doesn't change as that chemical throughout 20, 30 years of use. On the other side, there's medical devices, which were acknowledged to change to some extent, but they're kind of separate pillars of law with very limited connection between them. The argument that I make in my work is that this traditional separation doesn't work in the modern world. And it doesn't work when you have data and AI in the interface to the delivery of drugs, to the adaptive dosing of drugs. And it particularly doesn't work as we move towards a world of precision personalized drugs. And that can sound like science fiction. I think to many of your listeners, it might sound like science fiction. I don't think to many of the people attending the conference, it would have sounded like science fiction, because they're aware of how things like CAR T cells, CAR NK cells can have their receptors, at least in proof of principle, designed to the specific molecular makeup of a cancer of a patient. Now, this is very much at the level of proof of concept at the moment, but proof of concept moves stepwards forward through to medical practice, if regulation allows it to do so. And are we ready for medications which are specifically designed based upon AI interpretation of the molecular structure and the ligand structure of an individual's cancer entering practice? If we are, and I would argue if the evidence is there that can form part of approval systems, it shouldn't be because we are not ready from a regulatory perspective that we just say no to this. And again, maybe one other example of this, of where personalized medications are not science fiction, and where there are challenges in the regulatory frameworks. Like, you're probably aware of the work from BioNTech and also from Moderna in RNA based cancer vaccines. These are always called cancer vaccines, but they are targeted to individual patients' cancers. They're not actually vaccines. They're delivered after the cancer is already present. So they're treatments, they're targeted specific treatments which use some of the technologies that have been used in the past in vaccine development, and they use some of the concepts of immunological concepts of treatment that have been used in vaccines in the past. There are regulatory challenges on how we scale up the use of these technologies, and that's also something that I address I hope to address in my discussions at the meeting, and also that I addressed in the recent paper in Nature Portfolio on new regulatory thinking in precision oncology.